I definitely want to say thanks to Dr. Smith and Jay and the FMMA for having us. And I think this is pretty awesome to be, at the end of the day doing this conversation, because we have been talking about monopoly, the game, as a representation of what's going on in healthcare in America. And I think that you as a specialist and myself as a direct primary care doctor are really bringing this conversation at a time where people need strategy, just like they do in the game of Monopoly. So that is how we break the monopoly. When it comes to your practice in particular, I had the honor of being on stage with you a couple of years ago.
Yeah.
And it was really heartbreaking to hear something that many of us would have taken for granted. And that is that you didn't even realize that your patients weren't able to access your cash pricing. So could you please tell us what happened there, and how did that change your trajectory into how you practiced in the direct care space?
Yeah, it's pretty crazy. So I've been in practice for over 25 years now. And as a physician, I think, I always say my primary care colleagues are much smarter than I am, because they figured this out a long time ago, right? How to do direct care. And what I realized is I practice in my hometown. So a lot of my friends that I grew up with are small business owners, many of whom did not have insurance. Either they couldn't afford it or they made the value-based decision not to carry insurance. And these are contractors, realtors, restaurant owners, folks, your friends and neighbors, really. And despite having a self-pay policy on a piece of paper in a desk somewhere, like every practice has, we had that. But these folks were calling my office just saying, hey, I'm paying cash, I don't have insurance, I want to see Dr. Havig. And my staff was telling them no. And I would have never known this as a physician, except these people were my friends. So they literally called me out. They'd text me, they'd call me, and they'd say, Mike, what gives? You don't take cash? And I'd be like, no, of course I take cash. What are you talking about? And they'd say, well, your staff turned me away. And I don't know, it's just kind of crazy. And so I had to do a lot of thinking and figure it out and chat about that a little.
And I think it can be very eye-opening for us, especially in fee-for-service, when we are so busy doing what we need to do to get through the day. And this is something that I can easily see any physician who's in fee-for-service not necessarily thinking about. Like, what are the patients asking? How many phone tree buttons did they have to press to finally get a human being and then be told that's not an experience that we in fee-for-service typically experience, because we're just focused on getting through the next patient. Yeah.
No, you're right. And so I think that's the disconnect. I mean, all of us are busy. We're being paid less every year by the insurers and Medicare, despite our costs going up. And so you just kind of bury your head down and you just see more patients and you do more work. And, this disconnect, it didn't happen once or twice. It literally happened 30, 40 plus times before I figured it out. And I'd go in and talk to my staff the next day and say, what gives? Why didn't we make, Mrs. Smith's kid an appointment? And they'd always say, sorry, doc, we didn't know that he or she was your friend. And I'd say, well, these people want to give me cash. Like, we got a self-pay policy, And it just happened so many times. And what I finally realized basically was, with healthcare being retrospectively priced, like it is traditionally, someone comes and sees you or they see me, and we spend a little, X amount of time with them, 5 minutes, 10 minutes, 50 minutes, an hour and 15 minutes. That creates a CPT code, and we might do a lab or an X-ray, another CPT code. We might do a minor procedure, another CPT code. All that adds up, and it's always a crazy sticker price, charge master price of, call it $1,000. And Medicare might pay 100, and Blue Cross 150. And so healthcare is really the only thing, at least in the traditional world, where nobody knows what it's going to cost. So I could see 4 patients in a row and do the exact same thing, and I'm going to get paid differently for all 4 of those. The patient doesn't know what they're paying. The doctor doesn't know what they're getting paid. The staff doesn't know. I mean, it's just a broken system. So what I realized is if we want to be able to give somebody a price, whether they're a local, just self-pay patient or a self-funded employer, we need a product, and that product is the healthcare bundle. So most of what we do, we can bundle. And if we have a bundle now, we can use data to price it fairly for everybody. So I'm a big physician advocate. Being a physician, I want the physician to be paid fairly for their services. I often tell my colleagues that, hey, don't you think we deserve to be paid as much as the veterinarian or the dentist that you see? Doesn't that seem fair? Yeah, that seems fair. Great. There's your price. The employers like it because they know their costs, they're getting value, and the patient knows it. So if everybody knows a price and they can define what the service is, i.e. the product, the bundle, then we can all just make a value-based decision together and everyone's happy. So that's kind of what I started doing.
And that's great. And thank you so much for explaining what a bundle could look like, I think that, it's very pertinent to our audience, and that Dr. Smith was just on the podcast sharing about how he does bundled services at Surgery Center of Oklahoma. But share with us, because I was quite, intrigued that a bundle does not mean a surgical bundle.
Yes, that's true. So I think a lot of us think of surgical bundles, and obviously Dr. Smith's been a pioneer in bringing transparently priced surgical bundles to the market. The initial need I needed to solve for my practice was these office visits that my patients couldn't get in to see me. So whether they needed surgery or non-surgical care, they weren't even accessing me. So price the office visits first, which are pretty easy to do. And then I end up pricing everything I do in my practice, physical therapy bundles, imaging bundles, injections, durable medical equipment, and of course surgeries as well. But a lot of what we do as orthopedic surgeons, even though the word surgeon's in our name, when I look at my data, less than 10% of the people that walk through my door get surgery. So we're providing a lot of non-surgical care. So you really need to serve that side of the market as well. And I think that blends into where this is a direct pay is not just surgical specialists, any specialist, any primary care doc. We can bundle what we do. If you're a cardiologist, you can bundle. If you're a gastroenterologist, just about any specialty you can bundle. And so we've started doing that and helping our colleagues in those specialties build bundles as well for office-based care and minor procedures and office, minor surgeries and things like that. So.
That's great. And I think that working together to come up with different innovative solutions in different markets, it definitely makes sense that it's not just limited to surgical specialties. Mm-hmm. I think about the family doctors who do OB, the family doctors who do colonoscopies. There needs to be more of them for sure in both of those. But even the doctor who does PRP, POCUS in their clinic. So when it comes to doing a bundle, you've definitely succeeded in taking the bundle beyond your practice, and you've worked with, corporations who have surgical centers, employers. Talk to us about how you envision the bundle as, something to help bridge somebody if they're in, not their own specialty care practice or direct primary care practice, but they're still at a fee-for-service location, but they can then offer bundles.
Yeah, I think it's. We work primarily with independent practices. They're a little easier to work with than hospitals in most cases. I think everyone in this room would probably agree that trying to get a hospital to give you a transparent price is somewhat difficult. So I think there's certainly care that belongs in hospitals and in complex things that are difficult to bundle. But the majority of what we do is kind of bundleable, if you will. I don't think it's specialty specific. I think any specialty or any type of physician could bundle, right? Physical therapists can bundle, or providers, primary care docs, dermatologists. And it's just a matter of building out those bundles. And once you have a bundle library, it makes it easy to deploy them. So that's really what I like to say, our primary client when I work with people, it's not necessarily the insurer or the employer or any of those folks, although we work with them. My client is really the medical practice, and we kind of come in and help them, act really as a consultant, help them bundle. Many of the bundles we've already built, so we don't have to reinvent the wheel every time. And I think it's important to have the bundles be apples to apples, honestly, so people can really shop as far as what they contain. And then we have a pricing database, so we help them price, so we can really make it fairly easy for any specialty. And we've onboarded, our first cardiology practices, women's health, dermatology, ENT, and quite a few general surgeons and primarily hernia specialists, but also doing other general surgeries too. So it's all bundleable. It's just a matter of kind of looking at the data and figuring out what those bundles should include and what they should cost. So
I'm sure that there are other people in the audience asking this in their head as well, but when it comes to examples, can you give us an example? There's people building self-funded plans, community-owned health plans out there, as well as DPC physicians, orthopedic doctors who are doing, knee injections. Let's take that for example. How would you work that through the bundling process to be able to say, at the end of the day, this is the bundled price?
Yeah, so surgeries are a little bit more complicated. And what we do there is we can work with a medical practice, surgical practice, and a lot of them don't know their costs very well, quite honestly, but we can kind of help them through that. And so we used to go through a pretty onerous process of looking at a specific procedure called a rotator cuff repair. These are where they get complicated because it's multiple CPT codes, could be in a rotator cuff repair because there might be up to 4 or 5 CPTs involved, versus say a total joint where it's just one CPT, it's a little easier. but trying to figure out at what frequency they do 2 of those codes versus 3 or 4, how many implants the doctors at the center use, what are the costs of those implants, some use this company, some use that company. So it gets really complicated, but you can use the data to really come up with a price. And we did that on a number of occasions, and after enough at-bats at that, you kind of know what the price should be, and I think we give people a lot of guidance. So surgeries are the most complicated because then you need to get anesthesia to buy in, you need to get the surgery center to buy in, you have the surgeon buy in, obviously. Things like injections, office visits, a little easier, but again, if you would ask me, 10 years ago, what it cost me to do a corticosteroid injection in a knee, I would have had no idea. I could have guessed and maybe been somewhat accurate, but if you asked what I got paid for it, I'd had no idea. Now I do, but those are easy because you know the supply costs, right? And you know the time it takes and whatnot, or you can use ultrasound or imaging. And so really anything can be bundled. And we try and make these bundles more inclusive, I guess is one other thing I'll say. So, but not over-inclusive. So I think where some people failed with bundles early is they tried to, like a surgical bundle that includes PT, a preoperative evaluation, of this, or that. It's just difficult because there's so many different needs there. So what we try and do is say, okay, pre-surgical evaluation with the primary care doc would be X. And if that primary care doc is a DPC, you know the cost, right? I mean, it's already done. Surgery is Y, physical therapy is Z. And then if people need to go outside that market, say they live an hour away, they can find a therapist in their market. So I think trying to keep care local, and to do that, you have to be able to bundle every phase of the care cycle, whether it's office-based care. And it's sounds pretty daunting, I'd say, but it's I don't know, we've gotten pretty good at it. So we were able to bundle about anything, and we've had pretty good success doing that.
That's great. When it comes to the use case scenario, you mentioned bundle libraries. I think about very commonly on a DPC doctor's website, a DPC doctor will say, just like you mentioned, the cost of the syringe plus the medicine plus the needle, et cetera. We can compared to surgery and all the CPT codes, come up with this is how much the procedure costs. But do you have any advice or tips, takeaways for those people who are then, like Dr. Dana at Love Health mentioned the last talk, if we have the ability to then talk to employers, talk to self-funded, benefits advisors, if we're saying, this is the cost versus what it could cost you if you did it in, a Medicare reimbursement equivalent code. Do you have any advice on how to optimize that message to the employer, the self-funded benefits advisor?
Yeah, that's a great question. And I will say that it's kind of difficult. So we've worked with a lot of practices around the country in fairly large, kind of vertically integrated practices where they own their own surgery center and maybe even employ anesthesiologists. They own their own physical therapy. And you'd think it'd be easier in those situations for that large group to go to the local employer, the school board or whoever, and say, hey, we'll provide all your musculoskeletal care, cardiology care, or whatever it might be. So in theory, that works great. It's been difficult for those folks to do that directly with the employers because, the benefits consultant for the county or whoever it is, they have a way of doing their workflow and who they work with, and it's hard to come in and just do that on your own. So I think my advice to groups doing this to work with employers is, yes, make an effort to direct contract. You have friends that own businesses. I have a friend that owns a construction company, and so I can direct contract with him from his MSK care. He buys it, directly from my practice. But those are just tough deals to do at scale. I think you have to work within the ecosystem. So we try and work and advise, our client practices to work with nurse navigation companies, with TPAs, with broker advisors. A lot of the folks that are in this ecosystem here at FMMA and Health Rosetta, because I think that's the easier path, because if you're working with someone on that side of the table as opposed to the physician, those people understand better how to communicate with the employers. The employers, I think, understand better how to communicate with that group of people. But then it's a matter of getting more of these employers in front of a Health Rosetta type broker, right? And so that's what I tell people. And luckily we work with give a call out to the Orthoform Value Network, who I know Heath was here a little bit earlier. We've been working with them to try and get everybody bundled and priced. And now you can do it more at scale, right? As opposed to on an individual practice where you'd go to, work with Dave Chase and his group and his broker advisors. And the key is getting in front of those people who are the good guys in the business, as opposed to try and deal with some of the legacy models that are out there in our communities.
Awesome. When it comes to your staff. Your staff originally was not necessarily knowing what to do with the person who's asking for a cash price. And then you brought bundles to your practice. Do you have any advice for how people can operationalize their own clinics once they have a bundle library for their own services?
Yeah, I think there's a couple ways to do it. I mean, once you're bundled in price, then the question is, how do you get those bundles in front of patients? In our case, we help people do that digitally by giving them a marketplace page on their website. For the retail payers, I think for the employers, they're not generally going to buy something with a credit card off your website, but it's a matter of working with technologies that can help adjudicate the payments and things like that. So I think it depends what market you're going after. The retail market, in a lot of DPCs in my community, most of them aren't working with employers yet. Honestly, they're serving the same patients I started serving, which are the small business owners who are uninsured and underinsured. And those people, it's pretty easy. Use technology partners to kind of put those bundles up in front of people. And then, where most of our clients transact business, I mean, it still happens on the phone mostly, right? People generally don't go to doctors' websites. We spend money, we build these beautiful websites, but nobody really goes to them, quite honestly, or very rarely, I think. Not as much as we think, at least. So they're calling the office saying, hey, I want to see Dr. Havig. Instead of getting a no or a non-answer, or it's going to be somewhere from $200 to $1,000, or we'll run your card for $500 and then refund you or bill you more later, which is kind of what most people have done. Now they can say, hey, no problem. I've got a great program for direct payers. Your knee's hurting. Let me send you a link to buy the knee package. It includes a visit with the doctor, an x-ray, and a plan to get you feeling better, and it's X dollars. Pops up on the patient's phone. They can one-click Google or Apple Pay, finance on Affirm. We just kind of give the patient, I think as a physician, you have to try and give that patient that same consumer experience they're seeing with everything else in life. And it's kind of hard to do that on your own, but partnering with some technology partners to do that, it makes it really easy. So that's what we try and do, is just push the easy button on direct pay for these practices.
And how do you even bring up the option for those people who are retail patients when they're, our culture is very much invested in, I'll do what my insurance covers.
Yeah.
And for those people, it's very interesting when I've done this many times with my patients. I'll say, yes, you could do it that way, but you can also do it cash. Do you have any advice as to how to present that to patients?
Yeah, I think, it's difficult in part because sometimes you don't know what their benefit will pay for, but I often, like if I'm ordering an MRI or something I know can be fairly expensive, or even physical therapy, I'll ask patients if they have a high deductible, right? Like I'm not going to know everybody's plan. And so I'm talking on commercially insured patients to give them this option. And I say, well, if you go through your insurance, you have a $1,000 deductible, you're probably going to spend it. And it may take a couple weeks to get it pre-approved. This imaging center down the road will do a cash pay MRI for $400. Would you rather do that? And they'll say, yeah, that sounds pretty good. I can put on my HSA card, yeah. And so I think as physicians, we should try. I think part of our responsibility is, obviously is to take care of patients, but a secondary responsibility I think a lot of us forget about is we don't want to bankrupt them doing it. And I had a patient just in the not too distant past, it was maybe last winter, and they were a self-pay patient. I think they were maybe Canadian, and I had fixed their rotator cuff, right? And so that requires a lot of physical therapy. And I'd written a therapy prescription, and I guess we didn't have that conversation because the patient lives, 30 minutes away or something, and they're like, I'll fund therapy. And they came back for their next post-op visit, and the shoulder was a little stiff, and I was like, are you doing your therapy? And they said, well, I can only go to 3 visits. And I'm like, why? And they said, because it was too expensive. I said, oh yeah, you're cash pay. Well, where are you going for the therapy? Well, she was going to the local hospital system, and this woman was paying $600 for each therapy visit. So she spent $1,800. And I felt terrible, right? Because but that's, I think, something that I think about, more than most, but even like a lot of us just, again, you're busy, kind of like we talked about at the outset of the conversation. And I felt so terrible for this woman because I was like, well, if you were willing to drive a half hour, you could have bought 12 visits from our therapy for $875. So for the price of less than 2 visits. And so I think that we do have to, as physicians, we need to think more about that and give our patients guidance, which goes back to the need to try and bundle in price so you can serve these folks better, I think.
That's such a tough example, and definitely, hindsight is 20/20, and we can't fix that. But I would love if you could share examples of, because of bundling, because of, looking at what the transparent cost is. Can you give us examples of how healthcare has been more accessible, especially if there's a, primary care with a specialist working together because of bundled prices?
Yeah, I think so. So I think, the story I told about why I started down this path, most of these people, and it wasn't just my community. It's kind of a fun story. I was thinking, am I the only one foolish enough to turn away cash? And, like a couple nights later, my son, who was a sixth grader then, was like, I need a science fair project, Dad. And I was like, oh, I got an idea there. And so he enlisted his aunts and uncles, and we created a script and called all the local orthopedic practices in Southwest Florida. And guess what? 100% of them turned away cash. And then I'd talk to these docs independently. I was like, what's your cash price for them? It's like, oh, we got a list somewhere. Yeah, we take cash. And they didn't. And subsequently, we expanded that study to look at the entire country, peer-reviewed study. And more than 97% of large orthopedic practices didn't bundle or price. So there's a real issue with access to all care, but especially specialty care, I think. And I think that's tragic, because where these people end up, they end up in the emergency department, right? Hey, I sprained my ankle, or I hurt myself. A lot of them don't know about walk-in clinics that are a little less expensive, but the walk-in clinic ultimately often just says, well, go see an orthopedist. And they kind of go full circle, and they go through the ER, and then the practice has to see him because the doc on call and all the requirements. But at any rate, I think it's just terrible access to care. And I mean, orthopedic care is not such a big deal. If you have a fracture, certainly it is. But I think a lot of people forego care in all specialties. They don't get their colonoscopy because they don't know what it's going to cost. If they knew, like, hey, I can buy this for 14 or 15 or 1,600 bucks, they would do it. And I've seen examples of that. I had a patient recently, and this is a musculoskeletal case, but this was a kid in a family that's a local kind of small business owner. And he introduced me playing football. And I remember talking to his father a couple times. I'm like, well, just come in, we'll see him. I'm team doc for a couple of the schools in my area. But this kid came in, and I think they put it off for a few weeks. And it was just one of those surprise weird things that, he tore his PCL, but, I ordered an MRI, and the kid had like bone marrow changes and leukemia, right? And it was just lucky, right? Like, I'm not saying it was the direct pay thing, but part of it was he knew he could buy the MRI for $400, right? If he would have not had that option, he might have said, well, we'll just see if he gets better. And he tore his PCL, but yes, this kid, I got him in with the, pediatric hemonc doc, and he's being treated right now. I just saw his dad actually somewhere, but that's just like an extreme example. That's not going to happen all the time. But if people know they can buy healthcare for a reasonable price, they will buy healthcare for a reasonable price. It doesn't matter if you're making $20 an hour. If you can buy a checkup for a couple $100, you can get your whatever you need, see a dermatologist. I mean, I think it's just critical to give this large group of people access to care, because no matter how hard we try to improve insurance products, there's a lot of great options here at this meeting and at Rosetta, there's still going to be a very large chunk of the population that just goes without insurance, hardworking small business owners, people in our communities, and who can understand, like, hey, I can Apple Pay and go see a doctor, right? They can get that. So.
Yeah, absolutely. I say this frequently, that people are able to buy healthcare and not insurance, because just like I have a small business that cannot afford insurance in the traditional Buca sense, but they can't afford $79 a month to pay me, and their adults have not ever seen a doctor since they were, like in sixth grade. So it totally is a way that people can access care, and can be removing the barrier of cost is a reason why I do not access care.
Yeah. Well, yeah, that's the thing. And I think you make a great point. I do think, and I think most physicians don't realize this. Like, when I talk to a lot of docs about this whole concept of bundling and pricing their care, they're like, Mike, do these people exist? They're not in my market. They're here, they're there. And I can give them a million examples. And they're like, but they don't exist in South Dakota, or they don't exist in, Nebraska, or whatever the state is. And if we get them doing it, they say, wow, this is amazing. We're getting all this business. The patients are getting access to care. Like, it's a win for everybody. And so you're exactly right. People know how to buy things, and they can buy them digitally, or they can buy them directly. People know how to shop. And if you put pricing in front of them as a physician, guess what? They will buy your services and, get access to care, and you'll be the happiest. Like, I mean, I envy my primary care colleagues who are full-on DPC. I'm not full-on DSC yet. I mean, I still take insurance, but I'm trying to grow that side of my business, because it just makes my life so much more pleasant, makes my patient's life so much more pleasant, where you can just show up and do your job as a doctor, which is take care of the patient in exchange for getting paid a reasonable price in a timely fashion without a lot of headaches. I mean, that's not a lot to ask, I don't think so.
It makes me think about Dr. Grace Torres Hodges, who is here at the conference. She had shared that I think 78% of her patients were Medicare before she chose to go from podiatry as a surgeon to podiatry as a direct primary care surgeon or direct specialty care surgeon. So I would wonder if you could tell us a little bit more about what is the reason why you have not gone full 100% DSC.
Well, I think part of it is I generally, like as an orthopedist, in podiatry would be the same way. But I see people and I hopefully get them better and then they're gone. So I need a constant flow of patients as opposed to being, like I'd love to sign people up for subscription orthopedic care. I just don't know how many people would do it, but maybe enough. But that's the main reason. And I have 2 kids that go to very expensive, I have 4 kids, but 2 of them are very expensive colleges. So I'm just, I get a little closer every year. And I got a kid graduating this year, so I get a big raise on May 15th. So maybe I just need to step into it. But I think that's the way I do it. I was talking to a doc earlier out there in the exhibit hall, and they said, well, how do I just cut the cord? And I think there's a lot of fear. I think part of the reason people don't do this is they feel they have to cut the cord, right? And what I'm telling specialists, look, this is just another payer. It's another revenue stream. You're missing that revenue stream. We can make it easy for you, help you do the billing collection, digital, everything. And, you can still do all that. And then as this business grows, you can phase out other payers and hopefully keep your practice independent, because I think that's something else we could talk about is Medicare just cut us another 2.8% this year, over 10% in the last 5 years. Inflation has been 20% since 2020. And I think we need, people often say, well, do you see this picking up steam? And I really do, because I think just, this is kind of extreme, but I think our healthcare system's kind of in a death spiral, minus things like this, because what happens is employers, are now paying an average of $27,000 for a family of 4. The family is responsible for about 7 of that. The average deductible is $1,600. Well, guess what? Reimbursement, the physicians are seeing more headaches, we're getting burned out, we're under pressure financially because of inflation. We sell our practice to the hospital, or we go bankrupt and the hospital takes over it. Not to be the hospital, I shouldn't say they're the boogeyman for everything, but they kind of are. But at any rate, yeah, and then guess what happened? Cost is up 3 to 5x. That cost gets passed back to the employers and the loop starts again. And so I really think as physicians, we need, it's not just a nice to have anymore. We need better business models that will keep independent physicians independent so we can provide better value care, because all this care gets driven in the hospital. And I say this a lot to people in the ecosystem where people often say, well, this total joint is priced at this. Is that too much? Well, compared to what, right? Medicare reimbursements, the docs in the surgery center are probably losing money or barely breaking even. The hospital is charging $100,000. This is a pretty reasonable price. And if you want to have a vibrant, independent medical community, you need to pay people reasonable amounts of money. And, big orthopedic group, this client of ours in South Alabama, been in practice, I think they've been there for 40 years. I read it in Becker's, they're bankrupt, closing, 35 docs. My sister's a pediatrician in Charleston, South Carolina. She was down in February. I had no idea this was going on. They've had all these financial things. And so their practice is closing after, she's been at this practice for 25 years. And the hospital's just taking over. They're not buying them. They're just like, you guys are in trouble. We'll take your 40,000, patient base, and you guys come and work for us. And she's distraught over it because she doesn't want to work at the hospital. But she's close to retirement at this point anyway. But I keep hearing these stories of practices closing. So it's getting off track a little bit. But I don't know. That's what really energizes me about coming to a meeting like this. As Keith said earlier, it's seeing other people who get it, right, and that are trying to kind of move this whole direct pay, ecosystem forward. So
absolutely. And as you're talking about the economy, and I think about recession is a word that has been mentioned in the past few weeks as a big concern for our country. But what I will say is that what a wonderful time to be in healthcare, because we know that in prior recessions, we've seen that people don't shirk on their healthcare because they know that they need good healthcare to maintain being able to work. Is just one example. And I think that when we're presenting not only a relationship, but we're also presenting something that is affordable and accessible, whether it be a bundled plan or directly just paying for a membership. These are ways that people can see the difference that we're bringing to the market.
Yeah, I think so. I do think, I remember back whenever around 2010, 11, when Obamacare was kind of going into effect, patients would ask me, like, is this going to affect you negatively, or what do you think of it? And I remember my response back then was, I kind of almost welcome it, because I think it's going to force more of us to look for better solutions. Like, where you're just going to say, hey, I finally had it. I need to move into more, I don't know if we talked about direct care then, but I'm guessing part of those cuts and just all the headaches is what kind of spawned more direct primary care and other things that's kind of come a long way in the last 15 years. So I would agree with you. I think it's a good time to be an independent physician, because we are always going to be able to outcompete the hospitals on, I think, price and quality, quite honestly. Certainly price, and often in quality, I think. So it's just a matter of us having to understand, or it's a matter of us understanding that there is this other ecosystem out there, that there is an alternative, that, people talk a lot about at this meeting and at Health Rosetta, and it's a matter of getting that message out. So I'm excited to see how many people are here, and how the Rosetta meeting's growing and all that stuff. It's really exciting.
And for the people in the audience who are in the different buckets, whether they be physicians, whether they be TPAs, whether they be surgeons in particular, what do you advise them to take as the next step going after this conference in their own communities, but also to help them be a bridge between, if they're pure fee-for-service and then they're going direct, or they're direct but they want to do a little bit more with bundling?
Yeah, I think for those groups, I would say for physicians, we've really already talked about that a lot. It's just take the initiative to reach out. I'm happy to connect. Anybody can, I think my contact info is somewhere on the website here, the Hoove app. Reach out to me. I'm happy to just chat with you. But yeah, get some help, bundling pricing, getting things out there. I think from a TPA, employer sharing ministry payer side, what I'd like to see from that side of the market is more simplicity in how payments are transacted. So one of the, as I said, we started serving these kind of retail payers. And then when we started working with the self-insured community, one of my frustrations was we had a price that everybody agreed upon, right? It's X dollars. Doctor says that's fair, the surgery center anesthesia, the payer even, the patient, everybody's happy. But then to be able to collect that payment, you had to take this nice bundle and retrofit it into the archaic way of doing business, and go back to the standard process, which just slows everything down and costs everybody money, quite honestly. And so I would love to see the payer side work with people like us and our clients to agree on a price and just make that payment much smoother and easier without all the headaches. And I think it would benefit everybody. And, and I've seen it on the sharing ministry side as well out there, where we have a lot of sharing ministry patients that buy healthcare from our client practices. And some of those practices honestly have told us they don't want to take care of these people anymore. They don't want to take care of the people, but the paperwork they have to provide so that patient can get reimbursed has gotten to be very onerous, or maybe it always has been, but that's come to my attention recently, where we have one practice that they put on their website, we are going to give you a receipt, and we are not doing any of this other stuff. And I would love to talk to any of the ministries out there about how we could streamline that a little bit so these patients can get access care the practice wants to see and treat them, and not have to deal with a bunch of paperwork. So let's move the whole system forward, whether it's payments or pricing or technology. Let's work to make it easier for everybody, I think.
Fantastic. Thank you so much, Dr. Havig. We have about time for 2-ish questions. Do we have questions from the audience? So the question, just to have it on the recording, the question is, with bundled pricing, sometimes you'll see that complicated cases that are taken care of through a bundle end up in the hospital. How to address that? Yep.
Well, I think there's a couple of things. So first of all, not everything is bundleable or can be done at an outpatient center, number one. So I think I hear a lot when people say, well, what if this happens, or what if that, or what if this, what if that? That's going to happen. That is healthcare. And so I think, there are certainly services and surgeries and things that are more easily fit the direct pay bundle space than not, which is why we have hospitals, right? I think the second part of that question might be, people have always said, well, if you own a surgery center, are you cherry picking the healthy patients and the sick people are ending up at the hospital? Well, the flaw in that argument, I think, has always been, well, the healthy patients should be at a surgery center where it costs less money, and the sick people should be at the hospital, and the hospitals get paid to take care of the sick people. Like, it shouldn't be the same for everybody, right? So, I always quote Clayton Christensen, Innovator's Prescription, great book. It's about 15 years old now, but he talks about this, right? Like, let's pay the hospitals well to take care of sick people. That's what they should do. But everything else should move to a lower cost, lower acuity venue of care. So, thirdly, and the last part I would say is, there are a number of companies, one of whom is here, who we work with, that offers, complication insurance, for lack of a better word, where they will insure bundles to cover complications. So say someone had a joint replacement outpatient facility, you're the employer, you paid for that. Now the patient gets an infection, they're insurance products that will cover those complications. So I think if we think about those three things, that solves a lot of those problems. But yeah, you're always going to have the outliers that have to go the hospital route, but don't throw the baby out with the bathwater. Let's do what we can, and then deal with those more complex cases.
And we still have time for questions. Yes. So just to clarify, when people are wanting to incorporate cash pay pricing, what are the top 3 struggles to do that? So the top struggles to get cash pricing into their practices if they're not doing it. Yeah.
You're talking about from the physician standpoint or the patient? The provider standpoint, I think part of it's just a different mindset. I mean, a lot of people, I wish every physician would come to this meeting, honestly, because or meetings like this, because most people don't understand that this market exists, number one. If they do understand it exists, they think it's small. I think traditionally medical practices think of, there's the old saying, self-pay equals no pay, right? And so they think it's all charity care, every bit of self-pay. It's not. You can still do charity care. I still do charity care in my practice, as do most of our clients, right? But people struggle with that. And I've had people say, well, why do we want self-pay? I'm like, well, you're going to name your price. You're going to get paid fast. It's easy. You give your community access to care. And they're like, oh, so it's not like the cases we have to see, the infection that shows up from the ER. It's like, well, you have to take care of those folks too. But there's just a deep misunderstanding of what self-pay is. And that's why we call it direct pay, quite honestly. I used to say self-pay for these retail patients, and people just have these negative connotations of what that means in healthcare. So number one, it's getting over that. Number two, most practices that I talk to, they really don't know their costs, right? Like if you're a small business owner, say you're a plumber, you know what your pipes cost and you're this and that. And I think DPC, you guys probably know it better than most because you're running more of like a business instead of this nebulous third-party payment thing. But I think they don't know how to bundle and price. And that's where we kind of come in and help them do that. And so it's those two big things. Number one, does the market exist? Number two, what do I bundle? How do I build a bundle? How do I price it? And then the third one would be just the payment side of it. How do I make it easy for patients to pay? Give them financing options, things like Google, Apple Pay, just one-click, simple payments. Because what I think some practices start with this, they do the bundles, they do this, that, and the other thing, and then they're kind of like, well, yeah, I get these appointments and there's a really high no-show rate. These patients don't have skin in the game. My staff forgets to collect because they're just like, we'll bill your insurance. And that is why self-pay equals no pay to a lot of these folks. So you just gotta have a better process, and those processes are out there and exist. So it is a bigger struggle than you'd think, obviously, but we're trying to overcome all that.
So please connect with us on the Whova app and ask questions there so that as you ingest everything else at the conference and you have questions about bundling, please just drop us a message. Thank you so much.
Yeah, thanks.